All right, thank you. Thank you for that very kind introduction and the invitation to be here today. I do have one correction, the biographical sketch. I don't know why I didn't pick this up when I read it. I didn't complete a pathology residency. I spent 16 months in pathology, but I did complete the family medicine residency. I probably rotated through every service in this hospital more than once as a student and then as a resident. So it was a standing joke of what was I doing this month. I do want to express some gratitude to Fred Lucas, who was the chairman of pathology at the time. He rescued me, didn't understand what I was doing, and I didn't understand what I was doing, as well as to Jack Caldwell, who finally said, yeah, if you want to stay here in family medicine, I guess maybe you might have made up your mind what you want to do. So I've put a provocative title here. It's more to challenge your thinking than it is to provide a particular answer or perspective. Why have I always been interested in education? My dad was a professor of education at Michigan State University, and in the 60s he carried around in the trunk of his car a huge box that had collapsible wheels, and it was a Sony videotape machine. So he videotaped students doing their student teaching, and he says, you know, I don't have to say anything when they watch the tape about what they did well or what they didn't. As a student, I got involved in teaching when I was a pathology resident, the second year pathology course here with the man in the pan and course and case problems every week of a different nature were a phenomenal way to learn medicine and also to participate in teaching. When I went in the Air Force, I had the opportunity to participate in a residency teaching program. And so that's been sort of the nidus of my career ever since. So I picked a topic that's near and dear to my heart from a broad perspective. So we have some very simple objectives here. One is look at historical influences. Two, understand what some current trends, pressures, costs, and implications for our medical students of today and tomorrow in society are. And three, maybe look at some interesting ways in which we might do something different, but not throw out the baby with the bathwater. What are some of the major influences in medical education? Well, do we really understand what our end product is? I've been in 3 or 4 different medical schools, and when you ask the medical school curriculum committee, how do we define a successful graduate, it becomes, well, they've passed all the courses. They've passed step 1 and step 2 of USMLE. And we have maybe done a clinical OSCE, and they can do a general history and physical. They can define the problems that a patient has. They can come up with a differential and some idea what they might do. Okay, graduate. Now, some medical schools may do that better than others. We have no understanding of what they really know about cultural diversity, what they really know about professionalism, what they really know about safety, what they know about quality improvement, what they know about population medicine, what they know about cost-effective medicine. What does society need from our graduates today and tomorrow? Second issue is, you might say, what are the costs involved in medical student education today and tomorrow? How do we fund graduate medical education residency positions, and what do these 2 issues have to do with specialty choice? And what is healthcare in the 21st century supposed to look like, might look like, where is it going? So when most of us in the class of 1971 and other classes came to medical school, we just wanted to help somebody. We didn't particularly care who or exactly what the problem was, but just give us a patient and tell us what to do, and we're here to learn. And some people came with stars in their eyes and wanted to be world famous. Some people have, such as Dr. Longo. It's a compliment, Dan. But not all of us were in the movies. So let's go back and look at the historical perspective first, which is the first general topic. Everybody's heard of Flexor. Everybody knows he did a report in 1910 and has shaped medical education for over 100 years. Who was Flexor? He was the former headmaster of a private high school in Louisville, Kentucky. If you're from Kentucky, you got to say Louisville, not Louisville. Okay? But he wrote a book called The American College, which brought him to the attention of the Carnegie Foundation, and in which he criticized the didactic and elective system of many American colleges at that time. And they thought, well, here's some guy who knows something about the broad base of education. At that time, there were 155 medical schools in the United States, many of them proprietary operations, largely didactic, a little clinical, following people around, and if you did that, you got an MD degree. And there were others that had other models. So he went around with the sponsorship of the Carnegie Foundation and visited all 155 of those schools. And he made some recommendations. The recommendations were the Johns Hopkins model. And that is, you needed to have a 4-year degree before you entered medical school. The model was 2 years of basic science, 2 years of clinical teaching. We needed to produce problem solvers and critical thinkers. Experiential learning was important, and promote original investigation. That last one is probably really critical for why American medicine has been on the cutting edge of science and set a tone for most of the modern science discoveries in this country, along with the support, obviously, of something like the NIH. So what model did we have in the 1960s and 1970s at this institution? Well, I owe great gratitude of thanks to Ted Groshong, who I emailed, Mike Hasakawa, who got involved, and I believe it was Roberta Sternberg in the dean's office. I said, can you find a curriculum from 1971? And they said, well, we can find a medical school bulletin. So I've abstracted what we did in 1971 as the curriculum at that point in time. You can see that those of you who were here in those days remember Dr. Leeson and his textbook and his English accent. Owen Kepi, who ran biochemistry. Physiology was Dr. J.O. Davis, who was one of the discoverers of the renin-angiotensin system. And then we had human ecology and behavioral medicine, behavioral science. Now, if you take a look at the hours, we did a lot of sitting. Of course, there were lots of labs that students couldn't even conceive of today, like a nasogastric lab on a Saturday morning. I still gag thinking about that one. So we didn't understand, most of us being sort of conservative white guys, there were 5 women in the class, 2 of them are here today, what this human ecology behavioral science was. And I think some of us thought that we were going to have to be taught how to hug people. And we didn't come to medical school to do that. So F. Marion Bishop, Bob Freilich, Hans Mausch in medical sociology were our teachers. And while I think some of us appreciated it, I don't think we really understood what was going on. So you look at the second year, and we spent almost as much time. And it's interesting how the hours they're really added up. This was an important issue in the medical school. How many hours did faculty in the basic sciences get to teach? And of course, now behavioral science in the second year got cut down to 15 hours. But now we had this interesting phenomenon. Gee, let's teach them a little bit about radiology. Oh, by the way, microbiology, Dr. Frank Ingley said the bugs will win. We didn't believe him. I think the bugs are winning. And then there was D. Dax Taylor, who evaluated all of us at some point in pathology, and I imagine he told many of you, as he told me, he says, you're not living up to your potential. So what we knew about radiology probably encompassed 15 hours in that day and age. And if you'd have said, gee, I need a CAT scan, it might have looked like this. It hadn't been done. When I tell students today these ancient stories, the only way to look at a person's brain was to do a pneumoencephalogram and describe taking out spinal fluid and putting an air and twisting around in a chair up in the air. They go like, what medieval age did you go to medicine? So was Flexner right? Well, it's not about right and wrong, but what did Flexner say a little later in time? He felt that he had been somewhat misunderstood, that the one model or the scientific model that he proposed had been overinterpreted as that's what everyone ought to do. And he is quoted in later years as saying, science alone is inadequate to provide the basis for professional practice. You need insight, sympathy, and preparation for those kinds of personal qualities are more difficult to teach and inculcate. In later years, the medical curriculum had become overwhelmed with science to the exclusion of the humanistic aspect of medicine. We say medicine is an art and a science. We always have debated for years what's the appropriate balance. And in 1925, not very long afterwards, he said scientific medicine in America, young, vigorous, and positivistic, is today sadly deficient in cultural and philosophical background. It is said at that point in time that Americans were so enamored with what had transformed in medicine that nobody could tell them anything about what was the appropriate balance. So now let's move to 1970 to 2011. And what does the curriculum at the University of Missouri School of Medicine look like today? I've abstracted this from the website. I haven't put all the words into it. But what you see is 4 blocks. Do you see any hours listed? I don't. I'm sure there's some hour calculation somewhere. And every block has 2 components, an introduction to patient care and a basic science PBL, problem-based learning in small groups. Why is that? Well, it teaches people to think. But what we know from across the medical school environment today is students don't like lectures. If you have a largely lecture didactic curriculum, half the students or more don't go. And they don't depend on a note-taking service. They go like, I'll just do it on a podcast. I'll look at it on a CD-ROM when I want to. All right. These 3 blocks have an ambulatory clinical experience. It's a half day, twice a month. And so this is more basic science topics and what's covered, and there are a lot more than what I have listed here. So this is the curriculum in essence for the first year. This is the curriculum for the second year. Same phenomenon, divided into 2 parts, an introduction to patient care, and then this is a more disease-focused, integrative organ system phenomenon. And it's integrated in some part with what the introduction to patient care topics are. This ambulatory care exposure goes through 3 of these blocks, and advanced physical diagnosis is in 6 and 8. We have 7 clerkships. I couldn't find the exact determination of weeks or months for each one, fairly standard. And the 4th year is made up of 3 sub-internships functioning as an acting intern, a month at a time, one in medicine, one in a surgical discipline, and the other one can be whatever, I think. 4 general electives here at the medical school, and then an advanced biomedical science. This is an attempt by many medical schools, and I would imagine it's done better here than many places, to bring back basic science concepts into the clinical years and make them relevant rather than what you tried to figure out in the first year or 2, but you didn't know enough about clinical medicine to make it relevant. So we have a curriculum today that has advanced, that is significantly different than what was present in 1971. And 1971 was the Flexnerian model of medicine, of medical education. And that's pretty much what was going on all across the country. So a variety of parties, including the Carnegie Foundation, have said, let's take another look 100 years later at medical education. And they put out a new report, and I'll give you some highlights. What they've said is the following. We need to have standardized learning outcomes, read competencies, and individualize the learning process. Medical school is one of the few things in which you're lockstep. You don't, for some reason you were ill when we taught microbiology. Microbiology wasn't offered till the next year. And many of the things that we offer in medical school are exactly the same way. You can't go back and take it. People learn at different speeds. People grasp things differently. People have different backgrounds when they come in. But we make them lockstep and march in the same routine. Concept of promoting multiple forms of integration, not just a clinical case and a basic science. Promoting habits of inquiry and improvement and focusing on the progressive formation of the physician's professional identity. I don't remember that as exact topic in my medical school training. So if if you want to look at that in more detail, I didn't design or put this in here. This comes from Irby's article in Academic Medicine. But it details standardization and individualization, these four concepts a little bit more. But engaging learners in challenging problems and allowing them to participate authentically in inquiry, innovation, and improvement of patient care. Formal ethics instruction, storytelling, addressing the underlying messages expressed in the hidden curriculum. Now, you don't see any science listed there. It's assuming we're teaching them the science of medicine, clinical core skills in medicine. But what else do we need to be teaching them in addition to those fundamental things? Atul Gawande is an ENT physician in Boston. Dan probably knows him. Gave the Harvard Medical School commencement talk, and he said a lot of things, but he said the three skills medical students need to have that we perhaps have taught them, but maybe not so well. One is the ability to recognize when you've succeeded and when you've failed. We all think we know that, but what do we do with that information? How do we act on that information? How do we improve? How do we communicate, et cetera? Secondly, devise solutions for system problems. We now operate in complex systems. We operate in teams. We have data sets due to electronic health records and insurance company data that we never had 30 years ago. What do we do with that information? We say, well, it's about me versus the rest of the world, and I'm looking pretty good. Or do we say, how does our system function for patients? And thirdly, assemble, motivate effective teams. Rarely do we do anything, whether it's ambulatory care, emergency room care, operating room care, ICU care, hospital care, alone. We're doing it in teams with other professionals. And how do we manage that process? And what part do we play? And is it possible as a physician not to be the captain of the team all the time? Because maybe somebody else's expertise is what this patient in this episode needs, and it's not just about us. So, one other historical perspective. In the Lancet, an international commission looked at health professional education for the new century. This was an international panel of medical experts from literally around the world and put out this report. And they summarized what I've been trying to say very nicely, and that we've had 3 generations of educational reform in the past 100 years. The first one was a science-based curriculum, a la Flexor. The second has been problem-based instructional innovations to help people teach, to help students think more critically and integrate basic science with clinical medicine and clinical patient care. And the third is a system-based competencies, which is what they're proposing we need in the 21st century. So how does this look in another way? We produced, through most of the 20th century, people who became experts, most of us in this room. Whatever your field is, whatever your endeavor, whatever your subspecialty is, you became an expert. And that's highly prized in our society and our educational system. When you look at the PBL thing and the emphasis on professionalism, thinking, group, we started to produce people with expertise, but also as professionals. Not to say that those of us who graduated before this time were not professional. And the issue for tomorrow, these people are proposing, is transformative. We need to produce physicians who are leaders, who are change agents, who are system-oriented, who know basic medicine, but know and can analyze and lead effective teams in making things better. That's a different kind of challenge than we've been used to in medical education. So, the historical perspective would be that we're on the cusp of medical education transformation. And what do we need to know to make this happen? Well, we need to know something about the cost of education, the cost and funding of graduate medical education residency positions, specialty choice by students, and what our health system, how well it does in societal needs. So let's take a brief look at money. What you can see here, and I only went back a number of years, that public school tuition on average was $12,000 in 2001, $31,000 here. Debt rates were here, and we see some annual rates of increase. Actually, public school tuition has gone up more than any of the others. Currently, the University of Missouri tuition for an in-state student, or the median tuition across the country for public schools is $29,000. For private schools is $47,000 per year. Here, the in-state tuition is $26,000 and $29,000, depending on which half of the curriculum you're in. If you're an out-of-state student, it's $51,000 and $57,000. Compatible, comparable with what's going on in the rest of the country. In 10 years, there's been a 141% increase. And this has some implications, as you can see, from the debt increases, although they haven't increased as much. They've increased more than the private school tuition, but not as much as the public school tuition. So if we're talking about money, I don't remember a lecture that, how do we communicate about our fees, why we deserve to make a robust income? We all fought this, and this is a cartoon, so take it for what it is. Today, we're encountering that 86% of students are in medical debt. The mean between the average for private and public medical schools is $158,000. 25% of students owe over $200,000, and 10% owe over $100,000. That isn't chump change. What effect does this have on students' specialty choice? What effect does it have on eventual medical costs? What effect does it have on access to basic care? And what does it have to do with understanding populations in rural and inner city and underserved populations in our country? Well, let's expand this discussion just a tad. Here's figures from the AAMC on the indebtedness of medical school graduates. They revised it from 2004 down to 2007 due to better economic data, but they were predicting $1.7 million in debt. They've revised that to only about $750,000 in debt by the year 2033. This is given changes in the consumer price index, physician salaries, the cost of living, et cetera. So what? Now let's take a look, and it isn't terribly clear, but I'll give you the summary here. And they said, all right, here's what we predict income will be on a monthly basis for physicians in 2031, as an average or a median. And after all taxes, income tax, state income tax, local taxes, payroll taxes for Social Security and FICA, et cetera, the median income might be about $22,000. If you're paying off loans and the 10-year rate, you'll pay about $12,000 or approximately 50% of your after-tax income to pay off your medical school loans. If you choose the 25-year path, you'll be paying about $8,000 or 30 or 35% of your net income to pay off medical school loans at that point. But you'll be paying them off for 25 years with a lot more interest, presumably. Is that a sustainable, desirable picture? There really isn't any difference between the public school and the private school graphs. They basically, and when you talk about the indebtedness and merge it together, the implications are virtually the same. So the question might be, who will go into medicine? This information will not be secret. Who can afford to go into medicine? And is there anything we can do about this picture? So, does it have some other implications? Yes. In the United States of America today, primary care on median makes $190,000. General internists, general pediatricians, family physicians, and maybe a few other categories depending on your bias. The ratio of primary care to specialty salaries is 0.58. Data from other industrialized countries with well-developed healthcare systems indicates that the ideal ratio is 0.8 to 0.85. This figure is not lost on medical students. I'm going to make a lot less money if I do primary care than I will if I do a more remunerative specialty, and they know what those are. So students at age 23, 24, 25 basically are pushed earlier and earlier into making decisions about our healthcare workforce. So they pick the road. It's written up in the New Yorker. The road is radiology, ophthalmology, anesthesia, and dermatology. And the students will freely admit, I've considered the road. Nothing wrong with the road. I'm not attacking the road. But look, in 1960, 50% of physicians in America were involved in primary care. Today, it's 25% and 75% of people are specialists. Yes, medicine is more complex. It takes more physicians to take care of a complicated case. But it's 1 out of 1,000 people in a given month that ever enters an academic medical center hospital bed. Most of the rest of medical care takes place elsewhere. Less than 2% of all students go into general internal medicine, not just internal medicine categorical residents, and 10% of categorical internal medicine residents go into general internal medicine. What are we going to do without more general internists in this country? Pauline Chan, a physician, wrote in the New York Times 2 years ago, primary care has an image problem. It is seen by many medical students and people outside of medicine and medical educators as an anachronistic practice. Doctors who do not stand on the forefront of creative change, who are continually left holding the biggest bag of administrative expectations, clinical coordination, and demand. And having done this for a long time, I think it's true. We can all have stories, but I have an elderly patient who goes to Arizona and he goes see a chiropractor for radicular pain down his leg. He gets an electrical roller phenomenon. He's on Coumadin, and he tells him that. He ends up with huge bruising of his leg and swelling. He goes to urgent care, emergency care. His friends who are all out there with him tell him, go see a vascular surgeon, and he calls me up. So, well, you still on Coumadin? Have they checked your INR? Yeah. I said, I don't think you need a vascular surgeon. Get some support hose, elevate it, put some ice on it, call me. He said, Doc, I'm sending you a picture. 2 days later, I get a Polaroid picture in the mail of an elderly gentleman. I can just see his butt and his underwear and this horribly black and blue leg. All of this phenomenon evolved over several weeks. He got better without going anywhere else. There's no way to charge or get reimbursed for coordination of care. I would never dream of sending him a bill. But that's what happens, not just long distance, but every day in primary care practice. And it happens in other specialties as well. There are models of the patient-centered medical home that are coming into forefront, but they take a lot of infrastructure and support to make them work and to make them work effectively, and then you have to justify that increased cost effectiveness justifies a different payment system. It's a little bit of a catch-22, but it's something people are working on. So let's turn to graduate medical education for just a minute. We had 16,112 residency positions in this country, largely funded almost exclusively by Medicare. Does it make any sense that Medicare funds graduate medical education? To the tune of maybe $10 to $15 billion a year. It increased over these 20 years by about a little over 4,500 people. There was a Balanced Budget Act in 1996, and basically there's been very little increase, or less of an increase, in these years since that. A lot of them were funded by hospitals. In the meantime, U.S. seniors have gone up about the same amount, and the ratio of physicians to U.S. applicants has remained about the same. But the total applicant pool has literally almost doubled. And the number of positions per active applicant has dropped by almost 25%. Many people in academic medical education are predicting that in the NRMP match for 2012, we will see significant, good U.S. osteopathic and U.S. allopathic graduates unable to find a residency position. They won't be available. What are you going to do with a medical student with an MD degree, former medical student with an MD degree, $200,000 in debt, who says, I can't get a residency program? Why has this change occurred? Well, over the years, we've had 20 or 30 new osteopathic schools, often funded by private money. No new allopathic schools in the 80s and 90s because of the Geminic report that said we're going to have too many physicians. But now the AAMC said in 2000, increase your class size by 10, 20, 30%. We have 13 new allopathic schools in the accreditation process today. The majority of GME positions, as I said, are funded by Medicare. There have been no major increases. Right now, in the budget-cutting process in Congress, in the President's budget, the proposal is to cut the indirect medical education portion of Medicare GME from 5.2% to 2.6%. For those of you who are not familiar with this, IME is the larger portion of graduate medical education given to hospitals to support residency positions. If it goes in half, you're going to see hospitals start to scream bloody murder and probably say we can't afford all of this. Don't know if it'll happen. Competitiveness. We've got 10 to 15 applicants for some positions, orthopedics, dermatology, plastic surgery, surgical subspecialties. The students know that to even be a candidate to get an interview here, you've got to have a Step 1 USMLE score of 240, 250 or higher. Passing is 185. That's a limited number of people that they'll even look at. You can't expand surgical subspecialties very easily because they have to have operative caseloads. And those operative caseloads, you just can't add 1 or 2 residents per group, even if you could fund them out of clinical income, because you won't get accredited as having enough volume to train them adequately. So it's not real simple. Now, in academic medicine this year, there was a study, over 650 medical students, residents, following them for a number of years. And if we're using a major criteria of USMLE Step 1 and Step 2 scores for residency selection, what they had concluded was neither structured, coherent, nor evidence-based. It's a test of clinical knowledge. But the ACGME, who oversees all residencies, require that 6 competencies be taught and measured, not just clinical knowledge. This decision-making is not correlated with reliable measures of medical student, resident, and fellows' clinical skill acquisition. So we're backed into this box of taking people into residency programs that are highly competitive with limited positions on the basis of a score, and that's the only way they can even get an interview. And it's hard to tell a student who's a really good student, but maybe has a score of 220 that they can't get into dermatology. I interviewed a candidate for dermatology chair at one of my institutions in the past who worked half-time at the NIH and did dermatologic research, and he says, I couldn't get into dermatology today. Is there a bar above which it doesn't make any difference versus this bar when you think about who we admit into whatever? So you could say, gee, what I'm impressed with is medicine has become a business, and we as professionals have been dragged along. We should be business-minded, but perhaps the leadership of the medical profession has let this happen. A colleague of mine from North Carolina told me a couple of weeks ago that 5 years ago in North Carolina, there were over 300 private cardiology groups in the state of North Carolina. How many do you think there are left?
6.
5 or 6. They've all been bought out. So when you get owned, how much decision-making do you have? So let's talk briefly about some options. In education, do we need to continue to look for people who have basically a high MCAT score and a high grade point, and that's the ticket to an interview with 2 or 3 individuals on the admissions committee, and if they don't say the wrong things, and they say a few of the right things, they're in. And medical school deans take tremendous pride in the average MCAT score of our students has gone up from 10.5 to 11.5. We have smarter people coming into medical school. Will they make the best doctors? Oh, I don't know. And our average grade point's gone from 3.75 to 3.8 is the entering class. If you have children who've tried to get into medical school and didn't have those criteria, but you knew they were good people and they would make good physicians, is there something wrong with that picture? Maybe we should require biochemistry and physiology as prerequisites instead of organic chemistry and physics and some, not that we should eliminate all that, but that might cut some of the time spent in medical education. There are medical schools who are trying multi-mini interviews where you identify students with the right blend of non-cognitive and cognitive qualities. What that means is you have them go through 8 to 10 interviews in the course of an afternoon. Each interviewer has one question that they ask each student. They have their portfolio, they have their grades, they have their tests, and what they do is rank them on the basis of what they see the portfolio, but what were the range of answers to that one question. And out of 10 or 12 interviews, they begin to get a different applicant pool that might make some different choices about what they want to do in medicine. How do we address less cost? Well, there are some 3-year degree programs being experimented with. Texas Tech in Texas, McMaster in Calgary, Schools of Medicine in Canada, the Lake Erie Osteopathic School of Medicine. We did this in World War II when we needed physicians. There was a 3-year curriculum. You didn't get the summer off. You didn't get 26 weeks of elective time in it. Wasn't going to happen. It remains to be seen as to how well these people will do. Why does Medicare pay for graduate medical education? Why do we expect states and students to pay for medical education, but not the complete cost of it? Maybe insurance companies, hospitals, society, in some fashion, if medicine is a valued profession of service to everyone in this country, maybe everyone ought to contribute to the payer of it. Otherwise, we will only have rich kids going into medicine because they're the only ones that can afford it and picking areas of medicine that are extremely lucrative in our current system. Loan repayment for entering and practicing primary care. It's interesting, I got an email yesterday that the NIH has loan repayment programs for young scientists. I think it's a great idea. $35,000 a year loan repayment if you qualify, and $70 million put up in that fashion. We have loan repayment if you work in the National Health Service Corps, and some states have small loan repayment options. Some systems do. Maybe if we had competency-based advancement, people wouldn't have to spend 3 years and 4 years in medical. Some could get you through in 3.5. And there's a distributive medical school model which doesn't have a medical school building, but which uses digital long-distance learning, problem-based learning, team-based learning in the University of Northern Ontario. It's been in existence about 7 years. They've graduated several classes, and according to my Canadian colleagues, those students do as well in the Canadian system on standardized tests and competitiveness for residency positions as any other medical school in Canada. It's a much less expensive model of education. To be provocative and radical, the New York Times, not everybody's favorite newspaper, said, why medical school should be free? And they simply said, the students, somebody spends $2.5 billion a year on medical education costs for medical students. It's 1/1000th of our annual health care expenditure. Why don't we create a mechanism where everybody who goes to medical school, it's free. The medical tuition, not living expenses, not cars, that's your own business, are free. Students who end up in primary care get a residency stipend. They get a residency salary. Students who go into subspecialties don't get one. Radical idea. Don't think it will fly. But somebody's thinking outside the box. Another idea, fund all medical school direct expenses for students who pass a means test, personal income, family income, whatever, and who are willing to sign a payback provision. The provision would look something like this. They not only go into a primary care program, but they practice primary care for 10 years, and they don't owe anything. Once they bail out of that, they start to pay. Students who do go into a non-primary care program end up practicing in a non-primary care field, agree up front by this mechanism to pay 10% of their annual income for 10 years back to the loan program. So if you have somebody making $400,000 a year and they pay $40,000 a year 10 years into practice, they pay back $400,000. They're basically funding medical education for the primary care system and to some degree some graduate medical education. The fund could become self-sustaining. Again, a radical idea. Social engineering, we have a lot of concerns about those things. why is this important? Let's go to the 50,000-foot view for just a minute. This is a table from the Commonwealth Foundation in 2010 called Mirror, Mirror. It's rankings of 7 industrialized countries on the parameters of healthcare. Compared to these countries, our overall ranking is 7. That's not the best, that's the worst. Quality care is 6, effective care is 4, safe care, you can read this. Access to care is 6.5. Cost is 7. Efficiency, equity, long, healthy, productive lives is 7. This data is a little old. It's $8,500 per person per year in this country we spend on health care. Canada is the next highest. And what it says is our system, for the money we're spending, doesn't work very well for the majority of the population of Americans in this country. Now, when I show this to students, you can see some really puzzled looks like, well, my dad just had a good hip replacement. Excellent care. Yes. If you have access to care, you have health insurance, you have whatever, you can get outstanding medical care. Why does half the world want to come here and train? Because we do have an excellent medical care educational training system. But does it reach all corners of our society? Last week, we were ranked 41st in infant mortality. So I say to the students, you know, is that because we don't have enough NICUs, we don't have enough neonatologists, we don't have speedy ability to get people in for a C-section? They're pretty smart, and they go, no, I don't think so. It's a different problem than strictly a biomedical problem. So despite this, we're like everybody else, we're resistant to change, and how do we fight health care reform? I'm not advocating for the health care reform bill. I'm just saying, if you look at all this information, something's got to give. And we haven't had any really major new ideas in many years. So let me summarize. We have another transformation in medical education coming. The costs of medical education and indebtedness are a huge burden and affect our system. We don't know really what we're graduating because we don't know how to do competency assessment very well across the board of the biopsychosocial skills expected of our medical student. We have static or limited or possibly declining graduate medical education positions in this country. We have had a progressive decline in primary care, and those countries that do it well for the population and do it at less expense have a robust primary care system, which half the physicians in the country are from primary care. Our healthcare system is excessive in its cost, rapidly escalating. The quality is variable. You can find excellent quality. It's not always in the high-priced, big-name places. It is often in a community hospital that has developed robust systems and teams and measures quality and safety and continually improve them. Look at the data from the Dartmouth Healthcare Institute. In our healthcare system, what we spend is not correlated with outcome. The conclusion, to be provocative, is the system seems to be unsustainable in its present form. So not everybody is going to recommend change, but as this doctor says to his patient, gee, only 1 doctor out of 10 recommends it. There's room for growth and controversy. And finally, as Winston Churchill once said, one can count on the Americans to do the right thing once they've exhausted all other alternatives. So I think I have 1 minute over time. I appreciate your indulgence. My purpose here is not to say any one of these ideas is right, not to get you to agree with me about all these points, but just to simply say to stimulate your thinking. Those of you that are not involved in medical education, take a look and see what's been happening. And, you know, we as a medical profession, I think, have kind of let the business of medicine run the show. I think it may be time for the House of Medicine, in whatever fashion that can be described or defined, to start to take back medicine as a profession for the people of this country. And with that, I will quit. Thank you.